Good day, everybody from Miami. This is Dr. John Bennett, broadcasting for Neurosurgical TV. We have an impromptu hangout with Iype Cherian, MD, a neurosurgeon from Nepal. He's going to be discussing an overview of cisternostomy at the request of Bernardo de Andrada. I was talking to Bernardo just yesterday. This is the wonder of this tech. And he mentioned, I just did a cisternostomy. Boy, I'd like to talk to Iype Cherian. I said, okay, let's do it. So here we are. Let's introduce ourselves first before we start. Rajat, can you say hi to everyone?
It's me, Rajat, from Noble Medical College.
Rajat is from the hospital I'm going to, the Bharatnagar, the Nobel Medical Center. Welcome, Rajat. And Amar, good day.
Good day, John. Good day, Iype, and it's nice to meet you. I'm Amar Kadim. I'm a neurosurgeon from Iraq.
Welcome, Omar.
Okay, welcome.
Welcome. And Bernardo.
Good morning. My name is Bernardo de Andrada. I'm a neurosurgeon from Brazil, Rio de Janeiro. And I asked for Dr. John Bennett to talk with Dr. Iype about cisternostomy because we had a case in our hospital and we did it and we want to did it more. So we are expecting to learn more about the project.
Very good. And Iype, how are you?
Absolutely fine, John. Hi, everybody. It's a pleasure. It's an honor to be talking about this technique to all of you. So, shall we start?
Yes. Okay. Well, it's kind of free form. We'll structure it however you want. So take it away.
Okay. Right. So I'm going to screen share, John. Yes. Can you see my screen?
Not yet. Yes, I can. Yes, we can.
Yes.
Excellent.
Yeah. So can you see my screen now?
Yes, we can.
Okay. So we're going to be talking about cisternostomy. That's my wife and my child. And so the objectives here would be to discuss the mechanism behind cisternostomy, discuss on the evidence, current evidence on cisternostomy, and also discuss on the surgical techniques, study details of cisternostomy available on the net. In between, when you get bored, I'm going to show you a few videos. So let's start off by saying traumatic head injuries is the largest caseload and the largest problem for neurosurgery. There's no doubts on that. I mean, we are in large neurosurgical teaching hospitals, and all our aneurysms and all the skull-based surgeries and everything put together is equal to the number of traumas that we get. So it's 50% or more in most of the places. I'm not talking about Europe or small islands of neurosurgeries, but the rest of the world where the neurosurgery is done, maximally, we are looking at trauma being the more than 50% of neurosurgical load. But unfortunately, no microneurosurgery or any other advancements have been done in the last 100 years. It's often done by junior residents, and traumatic brain injuries are almost there. We are almost into pure conservative management. Now I see my friends who are ICU specialists and who are non-operating surgeons, mostly managing head injuries. They make all these protocols for surgeons like us. It's almost laughable. I'm sorry to be saying this. Some of my friends would be very offended, but sadly, traumatic brain injuries, people believe that no surgeries would help. And that's because the only surgical option right now available is decompressive hemicraniectomy, which is a century-old surgery. It's often a desperate last measure. It is done by junior operating neurosurgeons. And of course, the results, as you know, as you can imagine, it's very sad. Now, I was just talking about serendipity, that I accidentally mistook a traumatic brain injury for an aneurysmal subarachnoid hemorrhage. And as usual, I opened the cisterns, it made the brain lax. And then I extended this idea into other severe head injuries. We have a case series over 1,500 cases over the last 10 years. Much better results. Many surgeons have started opening cisterns in trauma. Now, what is the basis of cisternostomy? Well, like a surgeon, you know, we surgeons first shoot and then find out what happened. So like all true blue surgeons, I did cisternostomy and then I started looking why it works. So it is not the other way around. So when cisternostomy started working, we wanted to figure out why it worked. And then we understood that the edema that you see in cisternostomy is a completely different type of edema. This edema is because the CSF in the suprasellar cistern, it travels through the Virchow-Robin spaces around the vessels into the brain, creating edema. Now, this is a very crazy concept, but it's been proven. So, the CSF shift edema, let us look at it once more. So, all of us know that the blood vessels are in the subarachnoid compartment. Now, the perivascular spaces or the Virchow-Robin spaces, these are extensions of CSF space into the brain interstitial fluid from, excuse me.
Okay. A break in the action.
Later. I have a talk later. So the perivascular spaces are extensions of CSF space from the suprasellar cistern into the brain interstitial fluid. So trauma, this results in multiple small vessel injury and traumatic subarachnoid hemorrhage within the cisterns. So what happens when there is bleeding within the cisterns? There is pressure increase within the cisterns. This is like subarachnoid hemorrhage, but subarachnoid hemorrhage, the pressure rises to mean arterial pressure in a second or 2 seconds because it is a large vessel which has ruptured. But on the other hand, traumatic subarachnoid hemorrhage, here what is injured is the small vessels, the capillaries and arterioles. So the pressure is only 50, at the most 50. So the pressure slowly rises there in the cisterns. And this results in a rapid shift of CSF into the brain interstitial compartment from the cisterns. And this is brain edema. So this is the concept of CSF shift edema. Now we published this in this journal because we wrote it up and we submitted to many journals, and as usual, people thought it was crazy. So after we published here, then we published it also in Surgical Neurology and World Neurosurgery. If you search this article in World Neurosurgery or Surgical Neurology, you will get it. And now, do we have an evidence for this? Yes. Because our good friend from Calgary, Dr. Garnet Sutherland, a small introduction about Dr. Garnet Sutherland would be, he is the first man to do robotic neurosurgery in the world. And he has his own operating robot, which he designed. He was also instrumental in designing the IMRI. So Garnet, what he did is he's got this 9 Tesla MR at his place, at his disposal. So he did a weight drop model of severe TBI. And then he did MR on mice, of course, not on humans. After he did this on mice, he did MR imaging for early assessment to see if there is CSF shift edema. And he also looked at the histopathology, examining the extent of acute injury and neuronal astrocytic morphology. Well, he did a few other things also. So we are not going to discuss it right now. We are talking only about CSF shift edema. And this is Garnet's group putting the weight through the tube. It will go into the mice head and produce blunt trauma injury. So this is how they did it. And you see, this is pre-TBI MRI on the top. And immediately after, this is 15 minutes. 15 minutes after the trauma, you can see there is injury. But more than that, you see some bright spaces. I don't know. Can you see these bright spaces? Is it clear?
Yes, it is.
Right. So you can see, compared to the pre-TBI to the post-TBI, you can see that this brain is much more brighter. Now, why is it more bright? As a neurosurgeon, two things which can immediately make it bright. One is blood and another is fluid. So then if our proof to CSF shift edema is true, we should be seeing fluid inside the brain and blood in the subarachnoid space. That is our CSF shift edemas. That is the proof for CSF shift edema. So let us see. Now we looked at the mean MR image intensity pre-TBI and post-TBI, and we could clearly see that the pre-TBI was less brighter than the post-TBI, or in other words, the post-TBI image everywhere was brighter. So then we went into the histopathology. In the histopathology, you could not see any blood in the brain, but the subarachnoid spaces were full of blood. You see that? The subarachnoid space was full of blood, and there was edema. There was clear edema. There was also one phenomenon called dumping of tau protein, but that is not very important for us. What we saw was edema, and the CSF spaces were filled with blood. So this was a good proof to our theory of CSF shift edema. CSF shift edema so we understood that in cisternostomy, how are we actually reversing the CSF shift edema? Now, what we do here in decompressive hemicranectomy is, after the CSF shift edema has caused severe edema of the brain, we open that tense brain to the atmospheric pressure. This is the worst thing that you can do. You see, you make something very tense, and then you open the wrong door, and then the whole brain herniates out through that wrong door, and then you say that the pressure has come down. This is not the answer. Of course, it doesn't cause herniation inside the brain, but it causes herniation outside the brain, outside the cranial cavity. This decreases ICP. ICP itself is a wrong term, but it causes severe stretch injury to the brain. This is a wrong answer. And of course, we all know what happens after, after the decompressive hemicranectomy. There is severe damage, and the patient lies in the ventilator or in the rehab for ages. Now, the answer is open the cisterns into the atmospheric pressure. Now the brain has high pressure and the cisterns will have low pressure. The gradient will reverse. The CSF will shift back, and there is rapid decrease in edema. So let us look at a small look at this model. John, there is some disturbance.
Hold on. I'm sorry if I'm doing some other stuff. You can see it? Oh, no, it's okay.
Yeah, it's okay. Right, thank you.
It's everything. It's okay.
Somebody has to mute microphone.
Okay, let me see here. Oh, okay. Pratik, can you mute? Hey, I'll mute you, Pratik. Okay. I'll take care of it.
Yeah, it's okay.
Can you hear me?
Yes, we can hear you.
Yeah, so let us say that's a cistern, that's a brain. Now what happened? The cisternal CSF went in because cisternal pressure went up, and then all the cisternal CSF went into the brain. And the answer is not to open the brain here and allow the brain to herniate outside. The answer is there. You open the cisternal pressure comes down, the CSF shifts back, and that is cisternostomy. Or in other words, without the Mickey Mouse. So you have cisterns, you have subarachnoid hemorrhage inside the cisterns, the pressure goes up, so all the CSF goes in there to the brain, cisterns become small, no cisterns are seen. You know, one of the funny things I used to encounter is that most of the doctors don't know any physics. So I used to ask the people who used to criticize me in the earlier meetings, I used to ask them, yes, where do you think? I mean, you take a scan and you find that there are no cisterns at all. It is a severe head injury, very bad edema. The brain is swollen and the cisterns are not seen. Where do you think the cisterns are gone? So most of their answers would be, oh, it got compressed. You know, you cannot compress a cistern. Try and take 100 ml of water in a plastic bag and try to compress this. This is impossible. This is the basis of hydraulics. It can move ships. So obviously you cannot compress 100 ml of CSF. It is impossible. Some of them told me, oh, it went into the spinal canal. It is impossible because the spinal canal can accommodate only 40 ml of CSF to 60 ml of CSF. It's 120 ml of CSF went into the spinal canal. First thing we would have is a ischemic spinal stroke, because the spinal perfusion pressures will fall, because the spinal pressures would go sky high, spinal perfusion pressures will go down, and then immediately, and plus when Kocher did LP long time back, when the basis of decompressive hemicraniectomy, if you know, is Kocher said that there are signs of ICP, but there is no increase in spinal pressure. That is why he recommended decompressive hemicraniectomy. So obviously, if the CSF had gone to the spine, the spinal pressures would have been high, and Kocher would not have even thought about decompressive hemicraniectomy. So here, the cisterns have gone into the brain. This is not the cistern. The CSF in the cisterns have gone into the brain, and the subarachnoid hemorrhage remains there, and the brain is edematous. You open the cisterns to atmospheric pressure, and you drain the blood, and see, that is what happens. So this is cisternostomy. Now let us look at a few examples. I have a talk in YouTube where I have many scans. We have over 700 recordings of cisternostomies, 1,500 cases. We have many scans. We can sit down together with the scans for about a month or so. We can discuss these cases. But this is a case that is interesting because it's very recent. You see, what would you do here? You know, first things first you have to notice is, it is a very subtle case. It is not a case which looks horrible. That is exactly why I wanted to show you. This patient presented with a E1 M3V1. So here, people do not see much. They will say, the brain is okay. There is a small contusion here. But the most important thing here is there is no cisterns at all. The suprasellar cistern is not seen at all. This is severe diffuse brain swelling. Severe diffuse brain swelling. And if you see, this is the prepontine, this is the CP angle cistern. You know, when it is impending herniation, the uncus pushes the midbrain to one side, and the pons also moves. And when the pons moves to the same side, the CP angle cistern on that side widens. This is impending herniation. If you see this, please go operate. Don't wait. You can see here, it is almost herniating here. This guy's left pupil is dilated. He is E1, M3, and V1. So here, if you go and open decompressive, the brain will come out like toothpick. I can assure you this. Because there is a thin subdural hematoma there. You can see the subdural hematoma. You can see the midline shift. You can see the absence of cisterns. This is very, very bad. If somebody doesn't know too much about this, they will think, it's okay, everything is all right, I can manage ICP. ICP will be 40 or 50, and very soon, there will be no point measuring ICP. You see, again, this, see, absence of cisterns here, and this is after surgery. So we went ahead and opened all the cisterns. You can see all the cisterns are open here, very clearly open. This guy, post-op day, X2 extubated, E2M5, V2 versus GCS. No brain swelling. The brain is looking as good as it was before. Subdural is taken out. 10th day, discharged with a GCS of 15 by 15. So, yeah, I mean, this you can clearly see the cisterns are open here with some air and everything. So this is our paper in Varsha-Robin spaces in surgical neurology. Now I will go ahead and show you some videos. I mean, you must be getting very bored with you see, let me just show you some videos. So let me start off showing you the anatomy of cisternostomy. So it is a simple, after simple cisternostomy. So that is a optic nerve. Can you see me? Can you see this? Can you see my arrow?
Yes. Well, the arrow. Go ahead again, Iype.
Yeah.
Can you
Small
see
arrow.
it,
Yes.
Amar? Okay.
That's it. Yeah.
Okay.
Optic.
Yeah, so that is optic nerve, that is a carotid. The blood has been drained out, all the blood has been drained out, the brain is quite lax now. So that is we are opening the lateral carotid cistern. This is a video from almost 5 years back, maybe 2012 or something. Because at that time I used to operate with the molar microscope. Now we use a Pentiro, so this is MIOS, that means it's a very old video. So we are opening the lateral to the carotid, and you can see this is just like I do all my basilar deep aneurysms or my superior cerebellar artery aneurysms, or any aneurysms I do is this approach. I only know this approach. So you see that is a basilar. You can see that this is a superior cerebellar artery. That is a PCA. This will be basilar top here. So you see, we are opening all these vessels. You must understand this is a trauma brain. So to start with, it was not easy. She was very angry, and now she's okay. But this is every time. This is not like that. You must understand this also. Sometimes it is very bad. I will show you something very bad.
Nice photos.
Let us see something very bad. Okay. All right. Here we are. You see that is a subdural hematoma, acute subdural. You can see the pressure at which it is coming. So we opened not the entire acute subdural hematoma. We just opened a little bit of it, and then we are going into the cisterns. We are evacuating the subdural hematoma, following the orbital roof and entering into the cisterns. And you see after that the brain is quite lax, and now I can remove the rest of the subdural and then complete my membrane of request opening, and now you will see the brain how lax it is now. And I will show you how the lax. Now you can see the catheter into the prepontine cistern. You see how lax the brain is?
Yeah.
You don't have to, now this is another one, bus slope. So always cisternostomy sometimes is very difficult. Sometimes you open and then you do not find, so you can see the brain just coming out. You can see how bad it is, and you know the brain is just coming out, but it's okay. So you just go ahead and then you keep on irrigating. Now the brain becomes lax, you see. That is the optic nerve. You can see the CSF welling out.
You're getting subtemporal?
No, this is subfrontal. This is subfrontal.
Subfrontal. You go subfrontal always.
Lateral
So
subfrontal.
You
Optic
aim at
nerve.
mainly at the suprasellar system, you said.
Yes, yes, we are in the suprasellar system. Now you can see the brain pulsating. The brain pulsating. Small opening, 2.5 to 3 centimeter opening, and the brain is pulsating nicely. You have put the drain, and it is pulsating now. So yeah, I mean, so let us. I will come back to my presentation. Yes. So here we are. So cisternostomy is done to start with. It is done with a decompressive hemicraniectomy flap with adequate skull base, which means that the sphenoid ridge is removed. You evacuate the subdural, and after that you extend and turn the head along the anterolateral skull base, reach the optic nerve, open the interoptic and the opticocarotid space. After gaining some experience, this is my way of doing it, because this is how I learned over 5 years. My progress from just opening the cisterns, anterior cisterns, to, I mean, I was doing this along with the decompressive hemicraniectomy initially, because I found that if you do not open the membrane of reliquus, there is chances for rebound edema, and then you have to go in the night and take off the bone flap. So after doing this for a few times, I have an experience of 284 cases of decompressive hemicraniectomy with cisternostomy. They are not a good idea, but for a beginner, for a resident, I will generally suggest that. But after you open the membrane of reliquus, if you are an aneurysm surgeon, or if you Bernardo is already doing aneurysm, so it's very easy for him to open the membrane of reliquus, and then you can put in a drain, and then with some experience, you can easily keep the bone back if the brain is lax after surgery. And total duration from dural opening to membrane of reliquus opening is 10 to 15 minutes. And sometimes when you have no space at all to remove the bone, you should have maneuvers like anterior clinoidectomy, division of orbitomeningeal band, transcavernous dissection, posterior clinoidectomy, access to skull base in a tight brain. And this is all very, very fancy, and there is most of the time this is not needed. There is a beautiful paper published, case report published from Iran, Shiraz University or someplace where there is a neurosurgeon called Mashoud who has published, and he has not done anything. I mean, most of the time my residents or me also do all these maneuvers are not necessary. But I am primarily a vascular and an anterolateral skull base surgeon, so I like all these fancy things. But it is helpful for generally to avoid a lot of retraction in a very tight brain. Like all skull base tumors or anything, these maneuvers are very, very sometimes very useful. Now you might ask me, why not put a ventricular drain? A ventricular drain will work, but you must understand the ventricles have only 20 ml of CSF. They are compressed in trauma, and the key point is they do not communicate with the parenchyma. Cisterns have 120 ml and they communicate with the parenchyma through vertebromic spaces. Now, do you have proof? Yes, this is the proof. So, G-lymphatic pathway is a landmark paper written by Elif Nedegard and Helene Benveniste. Helene is a very good friend. So, they injected markers into the ventricle, they injected markers into the cistern. And the ventricular injection markers, after you injected A594, this is how the parenchyma look like. This is after they injected into the ventricle, this is how it looked like. The uptake was minimal. But you see, after half an hour of cisternal injection, you see what is happening? The whole thing is being taken up. So if you are going to drain the ventricle, the only way it helps is compliance. Because the brain is very tense, even draining 2 ml, it helps compliance. But cistern is not like that. Cistern decreases the CSF shift edema. Now, we have a paper where we discuss the anatomy and physiology of cisternostomy. It's a Chinese Journal of Traumatology. And then we have Asian Journal of Neurosurgery, where we have this paper. We have World Neurosurgery, where we have the pathophysiologic mechanisms and surgical technical notes, where we have talked about the CSF shift edema. And then, of course, these are dissections done by me in Paris in the WFNS anatomy lab of Christophe Destrieux. So this is the anterolateral skull-based dissections, and this is the anatomy that you find when you do a cisternostomy. Obviously, you don't find the small aneurysm like in this case, but for ACNS, we have these cadaver workshops, and I am in charge of ACNS educational courses. And this is my farm, which it is about 8 hours from the place I stay. It's on the hills. It's a beautiful place. Anybody wants to come, Bernardo, Amar, or somebody wants to come here, this is where we will put you up, and you can see our cisternostomies also. Thank you very much.
Thank you very much. That's nice presentation.
Okay, Iype, we'll leave it to the neurosurgeons to discuss. Go ahead, Amar and Bernardo.
So congratulations, Dr. Iype, for your presentation. I would like to show you the case I told you. This is the CT scan. Can you see it? I don't know.
Okay, I don't know. Could you guys see it okay?
No.
So
Yeah,
sorry.
it is almost, it is, can you put it up, please? Let me just,
Yeah, we can see it well. Yeah, we can see it well.
Yes,
Bernardo.
I can see it. I can see it very well. This is subarachnoid hemorrhage.
Yeah.
Severe
Arachnoid hemorrhage, and we tried this technique, and this is how the brain we found.
This is how we find it too.
Yes. So I would like to thank you to share with us the pitfalls, because we found some challenges, and I would like to share with you. The first is how large the craniotomy. We prepared for a decompressive craniotomy, but it's okay. And the second point is how to achieve the cisterns if you have a large severe edema without damaging the frontal lobe with retractors. We found this challenge. And the other point is the blood clot was very hard to remove. We found hard clot, not fluid blood. And I would like to do a question. Do you still use for some specific case this compressive, or you don't use it more?
Yeah, I mean, I will answer your questions one by one.
Okay, sorry for doing.
No, not at all, Bernardo. I have been answering these questions for almost 10 years now. So it is, but thank you. First of all, it is a brave step. Cisternostomy is a brave step. It is something which it is against something what we are taught. We are taught in a tight brain just to do a decompressive and get out. This is what we are taught. But for aneurysms, we cannot do this. We cannot get out. We cannot run away from aneurysm. So that is why you had to do this. But in trauma, if this had happened to you in trauma, most probably you would have just said, okay, I will do a decompressive and get out. But, you know, the size of cisternostomy, if you ask me, I have done cisternostomy with a suprabrow approach. So that will be a very, very small craniotomy, but I wouldn't recommend that. But it is not the size of the craniotomy. It is how basal you can get. So you have to go to the absolute base. If needed, take off all the sphenoid ridge, take off everything. If you saw my incision, I was right down to the base. So you, instead of making a C-shaped opening where the brain will start bulging out, you make an opening just above the eyebrow, as low as you can, and then use the orbital roof to guide you into the suprasellar system. Now don't worry about it. It's a dive that you have to do. You have to dive into that space. The frontal lobe will be overwhelming you. There is no question about it. The frontal lobe will overwhelm you, but just dive into the suprasellar system. There is no need to retract too much. You will hit blood. The moment you are in suprasellar system, you will have a lot of blood coming out. You just irrigate, irrigate, irrigate. Never bipolar, just irrigate, keep on irrigating. And then the brain will start going lax. Believe me, the next 5 cases you try this, you will see how much ever bad it is, the brain will start going lax. And once the brain starts going lax, then you can see the optic nerve, you can see the carotid. These are your first landmarks, ipsilateral optic nerve and the carotid. These are your first landmarks. And after that, you can slowly extend it back and then cut the proximal sylvian, go lateral to the carotid, and through either the opticocarotid window or the lateral carotid window, you can open the membrane of Lilliquist. And once you open the membrane of Lilliquist, you can put in a drain and you can irrigate out all the blood. Even if there is diffuse oozing, just keep on irrigating out the blood, the brain will become very lax. Now you ask me if there is an instance where I do not use cisternostomy. Yes. If there is clear-cut evidence of infarction, ischemia on the CT scan, then cisternostomy is not useful at all. There is no point. There are some times when there is severe, right now I have a case where there was a patient, alcoholic patient, who went and had a head injury, and there is severe ischemia. So when we took out all the cisternal fluid, the brain was lax, but it was getting full again. So we understand that, yeah, there is no point. So if there is evidence of infarction, it will not work. For sure, it will not work. Because the edema there is not CSF shift edema, it is cytotoxic edema. So
in this case, you treat conservative?
No, I do
decompressive.
I do decompressive.
Okay.
I believe that conservative is not treatment for anything. It is just waiting to kill the patient. You know, this is because decompressive is such a bad surgery. This is like comparing, you know, a rock and the deep sea. You know, they both are very bad. You cannot say one is better than the other. But waiting is bad. Waiting is definitely bad. Don't wait.
Yes,
Decompressive.
I agree.
If you have to do decompressive, do it fast. If you think that nothing is going, there is no use in doing anything, don't do anything. I mean, this is not conservative. This is giving up. So if I have to do something, I will do it fast. But in the last 5 years or so, I have done decompressive hemicraniectomy, which I can count on my fingers.
Oh.
Maybe less than that. So, but this is because I select my patients now carefully. If the motor score is 2 or below, if there is ischemia, so we have devised the Nepal Calgary clinical radiological score, and if the score is 5 to 15, we take. If it is more than 15, we do not take. We tell the relatives that there is no point. So this is why we do not have to do decompressive hemicraniectomies anymore. We are okay with cisternostomies.
Oh, good. Oh, so I think this pitfalls is very important for us, because we strongly agree that this technique can improve the patients, because we have been operating a lot of aneurysm for the last years, and many times we found what people call of angry brain with severe edema. And when you finish the surgery, after drainage of all cisterns to find and clip the aneurysm, you find a lack brain. So I strongly agree that it can work for trauma patients too. And Moreover, we are this compressive craniectomy has many complications. We have been front of many complications like bone flap infection and descent of posterior parts of suture, and I think it will help us to treat better the patients.
Yes, thank you guys. Thank you very much. And there are some videos on cisternostomy. I can just share with you a few videos. Ahmad, do you have any question?
Yeah. So you have a comparison with the results of decompressive craniotomy also, so that like the same outcome, or you only depend on the idea of the brain is flat and after the surgery, or there is a comparison with the outcome of
yes. So see, the thing is, I do not have a randomized control trial. Many people have asked me over the last 10 years, but I have my own series of decompressive hemicranectomy, over 700 of them, and I also have decompressive hemicranectomy with cisternostomy, 284 of them, and I have more than 1,500 cisternostomies. So I have compared the outcome of decompressive with cisternostomy and cisternostomy, and the mortality rates are something like 35 compared to 25 versus 15. So so 35 would be decompressive, 25 would be the actual figures. If you ask me, I would not be remembering it, but it is only about 1/3 of the mortality. The mortality and morbidity is so different. I mean, it is like you will understand that if you ask an aneurysm patient or a huge meningioma patient, if you do not use the microscope, if you allow a junior surgeon to operate, your outcome is obviously going to be bad. But on the other hand, if an aneurysm surgeon who knows how to handle the brain takes care of the trauma brain, the results are going to be different. So maybe it is my learning for sure.
Right. I would definitely, we agree that the morbidity that with decompressive craniotomy, we usually need the patient to come again to the theater for a cranioplasty, or for, if you keep the flap, you need to replace it again, and all these complications. Some patients, even some surgeons put shunts for this swelling the brain and the complications of shunts. So if in this case you basically are just mainly bringing the patient to the theater once in general, and of course
Yes.
it is cost effective, and mobility is less. If so this is a good gain, and it's very courageous of you to do something new and against the usual, and gain this good outcome. Even if it is comparable to decompressive, that will be also great, because at least we are saving the normal contour of the head and normal skull, avoiding cranioplasty that it has own morbidity and complications. Definitely, that will be a great.
Amar and Bernardo, I invite you to my center. Please come and see the results. You will not believe. Our patients walk out. We extubate within 48 hours. They will be walking in my rehab. Instead of the decompressive, I remember the decompressive, they'll be lying down on the bed for ages. I have many patients, people have done decompressives in other hospital, and they bring them to me now. There is no use. I have right now in my rehab, there is a 35-year-old man who had just an acute subdural hematoma, CSF shift edema. Somebody has gone and done a decompressive hemicranectomy and made him into a vegetable. On the other hand, I have another guy who came 2 days after that, acute subdural hematoma, much more worse, brain swelling. I have gone and we have done a cisternostomy. That guy is walking around now. He'll be discharged in 1 or 2 days. So if you see, you should come and see. I mean, I invite you both.
That would be great, but as you said, the point there is this type of surgery need much more experience than the decompressive, and therefore residents need to learn this early, so that because trauma is handled by residents at most. in most centers. So
we have
as you said, this will affect the outcome from this point. Is that needs some experience to explore this area in a difficult swollen brain. Yeah.
So
you're learning your residents early. Definitely, this is good, and they will reach this space early for later on aneurysms and basal tumors.
it will change the learning experience for residents, because right now the residents learn all kinds of bad things, like getting scared of a swollen brain and doing brain amputations. And you people post things in Facebook saying that I have done a brain amputation. What is a brain amputation? If somebody does a brain amputation, that fellow should not be a neurosurgeon. I mean, he should be some orthopedician.
I would like to know your center soon, and your farm is very beautiful too.
Yeah, and I saw one of the photos in a room. That's your library inside this.
Your library, farm library. Yeah, it's a very famous room.
Very nice to be there.
My center has its phase 2 inauguration. We have a brain suite. We will have a spine suite with arm and a minimally invasive suite inaugurated. This is being inaugurated in October, and we have a course with the European Association of Neurosurgeons and Asian Congress of Neurological Surgeons. We have cadaver courses. We have cisternostomy training. We have microvascular anastomosis training, workshops, everything. And the president of the World Federations, Franco Servadai, who is a very good friend of mine, he will be coming along with many other faculty, including Juha Harnesnemi. Juha is also going to be working here for some time. If you guys are interested, please, it will be an honor if you can come down.
Yeah, and I'll be there too, Iype. Don't forget.
Yeah.
Yes.
Yeah, and I'll be there, and I think you're going to see a lot more of Iype on the neurosurgical TV too, because we're trying to get this channel going and to interact. I was mentioning to Amar before we started that if he gets a group of Iraqi neurosurgeons, that you would be glad to talk to him about cisternostomy, and Bernardo also, if he has residents and other people that want to talk about it, that we can put you online.
I would like to.
Sorry.
I would like to congratulate you, Dr. John Bennett, for this channel. It's growing, and it will grow fast more.
Yeah, we'll get stronger. We'll get stronger.
Yes, it's a very interesting platform.
John is a workaholic. I mean, I'm sure the only way to go.
No one can do that.
Yeah, well, we look forward to growing in all areas of the world, actually.
Yeah, that's great.
So,
thank you very much, guys.
In this very interesting talk, and it's very honored. I'm very honored to talk to you. Thank you very much. I hope we meet someday soon.
Okay.
Thank you, Amar.
Anytime, Amar.
Thank you.
Slaven. Hi, Slaven.
Hello.
Hello. I hope you can see me. Hi.
Yeah, I can, Slaven. How are you doing?
Oh, okay, yeah. There's some other students that arrived after we started. Go ahead, say hi to everyone, Slaven.
Hello, Slaven.
For neurosurgery,
Slaven is a future neurosurgeon from Croatia.
Yeah, definitely.
He's very dedicated. And Pratik, can you say hello to everyone?
Hello, sir. I'm Pratik. I'm from CMS, studying MBBS in first year. I started this yesterday. But lot of just enrolled us in here.
Good to see you guys. Good to see you.
And your associate, could you introduce himself, please?
Hello, sir. I'm Losman Lucy. I'm also studying in College of Medical Sciences with Pratik. So I'm also roommate.
Yes, guys. So good to see you. Come visit Biratnagar sometime.
Okay. You know, they're going to be part of a group called the Neuro Sherpas. They're going to be students that are helping me in our project.
We we have a WhatsApp group called Go Green. Slaven is part of that. So we're slowly changing the medical college right now. So we're putting up a lot of trees and things like that. So
Yes, sir.
I have a group of medical students doing that. So I hope that you can visit us sometime. The place is becoming beautiful now.
Thank you very much for the invitation. I'm really looking forward to that sparring you promised me, because since you're in karate, it would be great to
Yeah, sure. We can try some mixed martial arts as well.
Yeah, I mean, it's, the spirit about it. The whole package. So
We'll have to work on that audio, Slaven.
Yeah. Okay, guys. Thank you very much. See you
Okay,
guys.
thank you, Iype. Thank you. I'm just going to hang out here.
Amar, Bernardo, thank you very much.
Thank you.
Thank you very much.
Thank you, Iype, for
Bernardo.
sharing these pitfalls with us. I'm very glad to talk with you. Hope to talk again soon.
Yes.
And someday personally.
Yeah. Bye, have a nice day.
Nice to meet you, Amar, too.
Nice to meet you, Bernardo. Yeah.
great to see you again.
Thank you very much. Bye. Bye.
Bye, guys. Bye.
Bye-bye. Bye-bye.
Bye.
Okay, I'm going to, okay, I'm sorry. I'm going to,
Okay.
yeah, you guys can stay. I'm just going to stay here and hang out.
We
If
are
you-
live.
whatever.
We still are live.
Oh, yeah, let me stop it. Okay, thank you, everyone, for coming. Okay.